This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.
And welcome back to the show. Thomas Perron joining us here from Perron Psychiatry. He's in private practice based out of New York City, New York. We're ecstatic to have him back here to talk more about how psychiatry really can help so many of you out there, whether it's with treatment, medication management, so many things. He's here to help you in person, virtually, and welcome back. How are you today?
I'm doing well. Thanks so much for having me.
Well, pleasure to have you here. So, for those that may not know a little bit about yourself in practice, would you
Mhm.
mind introducing yourself? Thank you.
Sure. So, as Jill says, my name is Tom. I'm a nurse practitioner. I've been practicing in psychiatry for about 30 years here in Manhattan. I right now have a private practice on the Upper West Side that I see folks essentially in a comprehensive way in person. And we also have a very robust virtual arm to our practice and still provide telehealth services through video visits. We practice pretty comprehensively and across the spectrum of different diagnoses, primarily, in the setting of depression and anxiety and bipolar and ADHD and PTSD and kind of the whole alphabet soup of most of the diagnoses that are out there. And so what we try to do right now, after spending a career in community psychiatry, is just taking a step back and seeing if I can make good on a lot of the things that I've been chewing my mouth off about access and consistency, because those are really two keys in the management of any chronic illness, but particularly in the setting of psychiatry. So I really appreciate you having me back. In trying to find me and access me, folks can use a website. Primarily, I've been using platforms, electronic platforms, several of them, and usually the best gateway to access me would be through like the ZocDoc platform, where that panel seems to be very easy for folks to access us. Although we do have our website up and running. It's tperronpsychiatry.com. And then there's also a link there to book online. And I would encourage anybody who has any questions or issues or concerns to not just access me, to access any mental health provider if they think that there's something going on with them or a family member.
And could you tell us about some of the things that you're helping people with? What are some of the things out there that maybe someone can kind of empathize and relate to
Sure.
today? Thank you.
Sure. So, when we look at the field of mental health, and when folks have a diagnosis, of things like schizophrenia and bipolar disorder, those tend to force us into treatment. It's very difficult for those types of
Mm-hmm.
symptoms to be overlooked. They come to the attention of psychiatry in various ways. Usually through emergency psychiatry and emergency rooms and medical offices. More challenge, and believe it or not, that makes it easier to access care, although clunky and emotional.
Yeah.
Um, However, the challenge of access to care is folks who um, are maybe not as impaired by their symptoms, but certainly are being dragged down by anxiety or depression, post-traumatic stress disorder, attention deficit disorder. And those diagnoses allow a patient to function at a certain level. And because many times anxiety and depression kind of come on slowly, we can develop skills to work around those symptoms until we get to a point that it becomes overwhelming. Now we're swimming, uphill and going uphill in both directions, and it's usually at that point where somebody reaches a point where they say, okay, this is enough for me, and I need to access treatment. Mostly it's the impairment in functioning, whether or not it's the ability to get by at work, to get by in our community. Many times these symptoms can spin out and cause interpersonal problems or family problems, because if somebody's depressed or anxious, it's very difficult to be present in any relationship, in any role. That's I think some of the nuances of private practice is to be able to not only help folks in the acute throes of distress, but to also improve wellness and a holistic feeling that they're on firm ground, and therefore can then move forward and really kind of manage what life is going to throw at us, because it's going to keep coming, and we just want to make sure we're on have a firm posture to be able to manage it when it hits us, and that's generally the focus of the type of treatment that I think is true in all mental health. But there are different levels to that. Emergency room, hospitalization, long-term, outpatient, partial hospitalization. There's many levels to this system, and unfortunately, they're all similarly difficult to access.
Got it. Well, thank you for that. And thank you for helping so many with all of this. Clearly, you
Sure.
are passionate about this work you're doing and you
Mhm.
continue to help people. Do you specialize with children, adults, anything
Mhm.
that we should just be aware of? And are you
Sure.
able to work with people outside of New York? Just want to confirm.
Sure. So, right now, during the pandemic, there was the emergency authorization use that allowed us to practice across state lines so that we could continue to provide access. Um, although we're still allowed to practice virtually, we don't have that reciprocity across state
Mm-hmm.
lines. So I practice in New York. So any patient within the state of New York can access me virtually. Although I do have many patients who access me straight out of the city and see me in person. Um, Now, the type of patients I see children, I see adolescents, and adults. I actually my Saturday mornings is it's seemingly the time where I have most of my children. They come my pediatric cases. They're all from school. Their parents are home from work, and Saturday mornings in my office can be quite exciting. So we see a lot of the kids then. However, adolescents. Similarly, a different type of treatment, but also include a comprehensive family approach. It is so parents are involved. Spinning a bit further, young adults and older folks like me, I also treat across the lifespan. And like we had spoken in the past, like any of us, we all have systems in place so that if somebody were to come to us for a consultation, we would easily be able to make an assessment and
Mm-hmm.
then a referral to the proper level of treatment, whether that be a more acute setting or in some cases to somebody who really does have a specialty within one niche of psychiatry. I practice generally, so I do see lots of different diagnoses. But after 30 years in community psychiatry,
Mm-hmm.
it's pretty easy for me to be able to make an assessment and decide the level of care, and then whether or not I'm the appropriate provider.
Great. Well, how did you want to enlighten us today? What aspects of your work and
So
health and
yeah,
wellness did you want to speak about?
sure. So, I was thinking about this a bit, and I think that one of the things that folks should understand is that there is several layers to the way that psychiatry is delivered in any community, but specifically in the one that I'm familiar with here in the New York area. And by what I meant is similar to what I referenced earlier about different layers of treatment and levels of care. When in what we just described is outpatient, it's either in person or virtual, usually on a monthly basis doing medication management. I tend to practice a little bit more comprehensively. If I start a patient and I meet them new, or I'm making medication changes, I generally see patients a bit more frequently, every 2 weeks or such, until we get them well, and then we see them less frequently. Now, that's kind of garden variety outpatient psychiatry, but there's many layers to what a patient may experience before they got to me in that level. And what I mean by this is hopefully not very long-winded, but in the acute phases of illness, we access the emergency room. And so we're talking EMS or such, and we get to the emergency room, and at that point, that level of care is intense. It's loud, it's scary. Nobody likes the emergency room. But when we get into the emergency room as a clinician, we make the assessment, and our goal for treatment is not wellness. It's safety, and it's to determine where that person is going to go. So my goal is, as an emergency room person, would be to get you out of my emergency room as fast as possible. Whether you need to go back home and see somebody and or make a determination if an inpatient admission is appropriate. However, it's a brief, very focused assessment and treatment plan that includes where do I land this patient to get the best care. And so in that setting, we then, if we take another step and we admit that person, now we're on the inpatient unit. Now that's another layer. It's a different setting. It's not as scary as the emergency room, although tend to be unpleasant. And we want to make those trips as short as possible. So if I'm a clinician in that setting, I want to get you off of my unit as fast as possible by way of making you well, but well enough to leave the unit, not well enough to spend 12 months in a very comprehensive, holistic sense of wellness, right? My goal is to stabilize you and get you somewhere else to another level. And so those two pieces, I think, sometimes get muddled together, but they're distinct levels, one acute and one a little less acute. And then we move to discharge, and that's when it gets very complicated and very, very difficult to access. If we're being discharged out of a hospital, now we're looking at outpatient care. Now, somebody like me in my role might step in. I do take hospital discharges from lots of different area hospitals. Many times hospital discharges in my practice require an in-person visit immediately after, so I can talk to somebody face to face. However, I might not be the landing point for many patients. There's partial hospitalization programs, there are group programs, day programs, what's called IOP, intensive outpatient treatment programs, and those are usually associated with big places. So on the tail end of now coming out of level 2 or layer 2, now we're talking about multiple settings and where do we land. The idea there is a little less clear because one patient may require much less, just come and get your meds refilled every month. Another may require psychotherapy and medication management and maybe a group. Another may require a hospitalization or a partial hospitalization program where they go into a setting 3-5 days a week and have a structured setting where they have clinicians and groups and community. And those are all different, albeit similar, different levels and intensity of treatment. And many times IOP and partial hospitalization programs are a little less, well, they're certainly less intense and comprehensive than the inpatient units, but they do provide a much more comprehensive and intense and frequent level of treatment than the next level, which would be somebody like me, in which case they come in, we do an assessment, all of that history, regardless of whether it's ER, inpatient, partial hospitalization, all that gets then sifted into my office. And then the treatment plan, now it becomes about wellness. Now you've gone through whatever that pathway has been to get to somebody like me. And now the idea is, let's keep you out of these settings again, to maintain wellness in a way that is either seeing somebody like me and in my office every 2 weeks, every 4 weeks. Some patients, once we have a really well defined treatment plan and a good effect, if we're able to, we cut them a little slack and we see them every 2 months, so that they don't have to, we're not pressing on their schedule to write their refills. So I think when we look at that sketch, and that's just the high altitude view, where we end up in outpatient psychiatry is generally at the end of the line. And what we do to be able to affect these changes in a therapeutic way should help us to avoid avoid those, excuse me, to avoid, I'm so sorry, to avoid those pitfalls that then respond to that we go through that process again. So meaning that if a patient comes to me and we suss out their history and we set their treatment plan, hopefully I've done my job correctly and the patient and I can move forward in their treatment plan and then keep them well so that the idea of managing a chronic illness is as simple as managing a chronic illness, like any of us, asthma, diabetes, any of those things that are well controlled, we can put them in the back of our mind and get on with life. And although mental health or mental illness seems like it's in a different category, it's not. It can be managed well. We can have symptom abatement, and as long as we maintain, again, access and consistency throughout whatever level of treatment that we were just talking about, the goal then it really becomes let's see how well we can maintain a patient without having the interruptions of acute or inpatient or high intensity outpatient treatment. So many times places like mine are the landing point for a patient to set a treatment plan and to develop a rapport with a provider like me so that we can have a long-term relationship and maintain long-term holistic wellness. Because at that level, we can then start to talk not only just about here's your Prozac, I'll see you in a month or two. We're talking about sleep and diet and exercise and relationships. We integrate with psychotherapists and we consult, pretty intensely, and so that we can then build an outpatient treatment team, even if it's virtual. I may speak to a therapist in Buffalo or in Albany that's working with a patient who lives up there, and I'm their med provider, and there's their therapist, and they may have a social worker. And once we can coordinate that, now we have a comprehensive outpatient treatment team, all with the focus to keep this person well and to keep them out of those very acute areas by way of making sure we're managing their symptoms properly.
Impressive. And clearly you are so passionate to be helping, so many people, and you are dedicated to this. And could you share a story or two about a client? You don't have to use their name, obviously, but about
Sure,
some of the
sure.
things you're able to help them get through.
Sure. It's an interesting thing to talk about cases that strike us. And in 30 years of seeing 20 patients a day, there are lots of stories.
Yeah.
And there are some that when we look at mental health and the integration of it within somebody's life and within their family and such, and
Yeah.
it can get a little upsetting. So I'm going to take a little breath and tell you a little bit about a kid a young man, not a child, who presented to my office in a state of somewhat overwhelming distress. And part of the issue wasn't such that his symptoms were so terrible,
Yeah.
but it was that he was somewhat felt often by the system. He had no provider and knew that he needed one. And many patients will try and do the best they can to stay out of any doctor's office, myself included. I don't like going to my doctor's a lovely lady. I don't like to go to her. And even maybe when I should go, I don't, and try and muscle through. And that is, I think, more true in places like depression. And so this young man who was fairly depressed, I met for the first time and showed up in my office. And after making an assessment, it really turned out that he was in quite a great deal of distress. And now the idea of what to do was difficult. And because we have to make sure the patient is on board with what we're going to move along with. And so this young man was in a state of crisis and concerned me for his safety. And the idea that is problematic in my world is that, it's heartbreaking and you want to do something. You want to just wrap them up and tell them it's going to be okay. But ideally, what we need to do is call an ambulance and get them into that system that we just
Yeah.
described. And so in this setting, and what do you do? Do I send this young man and say, "Oh, please go to the emergency room," and put him on a subway platform as he got out of my office telling me about suicidal thoughts? That's unacceptable. So now the interventions become very difficult and challenging and emotional. And in this setting, we accessed his family, and they came, and I met with them, and we were able to spend an extra bit of time to help mom and dad. They're come and help their guy, and so they brought him to the hospital, and he did well. And thankfully, we made this intervention. In retrospect, after following up with this young man, he's doing very well now. But in following up with this young man, the decision that he made to come to my office was on the other side of the coin that he was going to commit suicide.
Oh,
So in coming into my office, he thankfully took the pathway to get to me, as opposed to walking. He had a plan to kill himself off of a bridge near my office. So thankfully, he got into the office,
yeah.
and he was okay. It was a very, very difficult visit. He's a wonderful, wonderful guy. And now, after a brief hospitalization, he was stabilized and then discharged to me. And so when he came back, his parents came with him, and he had felt better. We had integrated a little bit of his treatment plan. We took what happened on the inpatient unit, which again is just enough to get him back out into the world and off the unit. And so we were able to really take that as a foundation and move that treatment in a way so that now he is back in his junior year undergrad here in the city, full time, and he's on meds and has no symptoms. He is able to now put those symptoms in the back of his mind, but it should stay close in the back of his mind, because we have to be vigilant that this won't happen again. The real horrible thing about depression is that it's actually called recurrent major depressive
Oh,
disorder,
wow.
because we can have these episodes recur even with long periods of time in between. And that story, although it kind of pulls at my heartstrings a little bit, I like this guy a lot. He's a wonderful,
Mm-hmm.
wonderful kid. But it repeats itself over and over and over again. And luckily for me, I was able to access his family and get him into the proper level of treatment. The real challenge becomes, where do where do all the other folks go who don't have those resources,
Oh,
who don't end up in my office
yeah.
or don't have family that can scoop them up and get them in? They may not have insurance, and that makes it very difficult to get them into the hospital and then get them out of the hospital. All of those things become difficult, because what I've described here today is based on the clinical outcomes. And unfortunately, this system is driven many times by what the insurance outcome is, what the financial outcome is, what the compensation outcome is. So a patient may get hospitalized if their insurance company tells me, as the inpatient provider,
Yeah.
that we're going to, we've admitted them, and they say, okay, well, we'll
Right.
pay you for 4 days.
Yeah.
If I have to keep you for 14, my hospital administrator is not going to be very happy, and I'm going to be under
Mm-hmm.
a great deal of pressure to
Yep.
try to get you out for the time that I have paid for. And so those are all some of the challenges. But uh, luckily, Jill, is that we run into these scenarios where we have happy endings.
Yes.
Where this young man that I described is doing so well. And I will tell you that although the media and such, we hear about the terrible stories and the terrible outcomes, orders of magnitude higher are the positive outcomes. Engaging in treatment and developing a rapport with a provider, 9 times out of 10 will provide and result in wonderful results. the diagnoses that we've discussed today and in the past are all very treatable. And so I think, in our last few moments here, what I'd like to be able to tell folks who might be fortunate or unfortunate enough to be listening to me drone on today is that if there is a question,
Yeah.
if there is a concern for yourself, for somebody else, don't wait and don't sit on your hands. Don't let it get worse. Access treatment. And even if the determination is that the
Yep.
level isn't one of those that we discussed today, if you at least access the system, you have a way in. There's a crack in the facade so that if and when, God forbid, something does happen or a symptom gets worse or a family member needs help, there's at least a contact point within that system. Many of us are like me and
Yep.
know the system well and can guide people. Whether I treat them or not, I will try and help most anybody try and access what they may need.
Got it. Well, thank you so much for that. And wow, we are just about out of time. We got 3 minutes left in the show. So how did you
Okay,
kind
yeah.
of want to wrap things up for today?
Sure. So, I think, in wrapping up today, that's hopefully we've, and again, it's a very broad sketch or a
Yeah.
primitive sketch of the mental health system at large. It's many, many layers. I could likely wax on about each one of those layers and the challenges and benefits of each one. However, I think when we look at the meat and potatoes of this, is that if we have questions or concerns or symptoms, we want to make sure that we identify them and don't do like me. I love my doctor and I will see them and make sure that I am okay. But not only when we're very, very sick, is to make sure that we take advantage of the pathways to global wellness that are available to us. And that would be reaching out and accessing somebody like me. It's not everybody that accesses my website or my office that I say, okay, yes, I need to see you every week, and here's the medicines and everything. There are times where I tell folks, hey, there's a great therapist out there who I can help you
Yep.
find, and try that. And if something else happens, I got you. I'm with you. But it may not be that a patient needs intensive psychopharm, from my office. But if the relationship can be established, God forbid it's ever needed, but if they need it, now they have a phone number and a name and a face that they can at least access to make sure that that we're not going to overlook anything and that they don't have to continue to kind of white knuckle it through their symptoms. It's not necessary. Folks can access the system, albeit difficult at times, but once they do, the pathway then becomes similar. Not as maybe dramatic, but similar to the story that I shared about my young man who's doing so well, and that's really, I think, what to take away is that despite how difficult it may be to access that, on the other
Got it.
side is
It's
a
always
sense of wellness.
beautiful. Thanks to your help and your services. Thank you.
I
So
appreciate you.
how can we contact you? Would you mind sharing once again?
Sure. So anytime that anybody needs to access me online, they can get all my information either at tperronpsychiatry.com. I also have a very robust calendar that is available on ZocDoc.com. My office can be accessed telephonically, albeit we're somewhat busy, at my phone number at 631-743-6647. Ideally, the easiest way to get some time in my office would be through the ZocDoc platform or the online platform. And then from that point on, we make telephone contact and emails and set up appointments from that point. And that's likely the easiest way to access
right.
me.
Thank you so much. Have a fantastic day. Gotta run. Bye.
Thank you, Jill. Bye-bye.
This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.